Hi, everybody, and welcome. I'm Dr. Laura Lieberman, and I'm really, I'm delighted. I'm delighted to invite you. I'm invited to delight you, both of the above. I'm really glad that you guys could come. This is the first lecture we've done in this format. In the summer, we have lots of students, high school, college, medical school, and we put together a series of talks to bring together all of the students, and they were very successful, and so we thought it would be a nice thing to continue during the year. So this is really one of our summer student seminars, and it's summer outside, so I think it's pretty much appropriate. So we wanted to pick a topic that would resonate with everybody, and I think the topic of immigrants and cancer screening is one that is particularly resonant. And we have a fantastic speaker, Dr. Abraham Aragones, who is in our Immigrant Health and Cancer Disparities Service. And he is himself an immigrant, and maybe in addition to teaching us about this topic, he'll tell us a little bit about his history. So I welcome you all, and take it away.
Thank you. Thank you so much for the invitation again. Let me see if I can make this. Can you hear me? Oh. Let me see if I can make this work. All right. I am very hyper, and I can't stand there. So I'm going to be walking a lot, and you might just need to follow me. So thank you for the invitation. My name is Abraham Aragones. I am an immigrant. I was born in Peru. And went to medical school in Peru, moved actually to the United States many years ago to finish my career here and concentrate in public health, which is what I'm interested in. I'm an internist as well, but most of my time is dedicated to public health research and health disparities research, etc. Migrating to the United States for me wasn't difficult, and I'm just going to be very honest. I actually moved here with a visa. But I moved here with a visa sponsored by one of the hospitals in the area or the school. So my story as a migrant is actually fairly unusual, believe it or not. If any of you are immigrants or know immigrants in the United States, most of the immigrants in the United States actually moved to the United States through their families. That's the majority. It's about 60% of us actually move here when a family member requests us. So a spouse, a child, or parents can be done beyond that, but that's the main way of migrating to the United States. So a very small portion actually move here with visas like myself, with the H-1 visas. You probably know, or some of you actually have, the J-1 visas, or just for some of us actually migrate here only seasonally. So to do work in some farm, they migrate here with specific visa for 6 months, etc. All of us are actually immigrants. We move from another country here, and we're leaving. We're residing in this country, and that's what makes the difference between a visitor, someone that just shows up with a visa, with a student visa, or I'm sorry, with a tourist visa, versus someone that comes here with any visa, including a student visa, that decides to reside in the United States. Okay, live in the United States, etc. It might be just for a short period of time, it might be for 6 months, 2 years, or their entire life. But while that person is here, that person is a resident. Okay, that person is living in the United States. So what we're going to do today is we're going to try to do a few things. I have a lot of information. I only have 1 hour, and I'm sure many of you are very interested in pushing me to talk about politics, which I'm not going to do. I'm going to try not to. So I'm happy to answer any questions as we go. I really hate to make this as just me talking and talking. I have 30-something slides, and I can just go through them and read them to you, and you might fall asleep or check Facebook. But I'd much rather you just ask me any questions as we go. So I'm going to try to start with a background on immigrants to make sure that we all understand the immigrant population in the United States. We have different levels of in terms of education here. So I want to make sure that, or involvement in the immigrants and immigrant issues. So I want to make sure that we all are in the same page. We're going to talk about immigrant populations. Maybe this is the area where we might actually enter into a bit of a politics, etc. We're going to talk about barriers to access care, and what are some of the issues to actually for our immigrant populations to access any care, specifically in this case, access in cancers.
May I have your attention? May I have your attention? This is the Fire Safety Director speaking.
You're this close to avoiding my talk, so. And finally, we're going to talk about cancer screening and prevention disparities, and I'm going to just show you a lot of information that is out there, including some of the work that I do as well. And again, this is just background.
Can I interrupt for a second?
Yes.
Is it okay? Can we ask what the level is of the students who are here?
Absolutely, yes, please.
So how many of you guys are in high school? Show of hands. Welcome.
Cool.
How many of you guys are in college? How many of you guys have finished college? How many of you were just in the area and you saw the cookies? Any medical?
Me too.
An honest person.
How many of you are willing, and you don't have to, are willing to say that are immigrants actually or move here? It's a personal information, so you don't have to. Good. We have a large number. Excellent. Cool. Okay. So if I'm saying something that is actually too basic or too or the opposite, please let me know. Okay, and we can explain again any questions as we go. You don't even have to use, raise your hand. You can just yell the question. We're about 325 million people in the United States. This is the entire population. I believe we're the fifth or sixth largest population or country in the world. About 42% of us are actually immigrants, or 13%. This is actually the largest percentage actually in history. Oh, come on, next time give us all the information. So we're about 42 million people. If us immigrants in this country would be a country, just the population of a country, we would be somewhere around 20 to 25th largest country in the world. That's how many we are. 13% is actually the highest in the history of the United States in terms of the percentage. And of course, the absolute value as well. This includes, 42 million includes, and we're going to talk about this, includes documented immigrants, undocumented immigrants, refugees, all types of immigrants. And we're going to discuss some of those differences in a minute. One thing that I wanted to mention here is that look how many, the majority of us actually moved here before 1999. About 2/3 of us migrated before 1999. And this is going to come handy in a little bit. But again, we're not all new immigrants. Actually, the minority of us are new immigrants or recently moved to the United States. This is actually a pretty cool number. In the United States right now, every 9 seconds there is one more immigrant. And every 29 seconds there is one more immigrant. So that's how fast we're growing. Now, we're not growing as fast as we used to. The immigrant population is not growing as fast as it was growing in 1998, which was actually the peak of migration, which was every 16 seconds there was a +1 immigrant. Nor are we growing as much as we were growing in the 2000s. With everything that happened in 2000 and with all the issues with migration, especially immigration, especially in the early 2000s, right now we actually have less immigration than what we used to have. But still, we're a growing population. Any ideas where most of our immigrants come from? Let's say 2016, where most immigrants came from in 2016? What countries? You can just yell countries. I'm sure you know countries. You can totally know countries. Oh, come on, man. You can just, yeah. All right, I'll give you the answer. So no one actually is even guessing. So Philippines, all right, you're very close. That's the number 4 last year. So the 4th largest population of new immigrants in 2016. Any other country? China, the second one. Someone said China here, the second one. I have some issues with that, but as a whole South America, yeah, no, it's not. So if you tell me more specific, I'm sorry? Just Peru. No, we're actually a fairly small immigrant population. Very few migrated last year, actually. Things in Peru are not as bad as they used to be. And you can tell, actually, when a lot of populations are coming from a specific country, most of the time there are a lot of things happening in that country. There are economical issues or financial issues or civil war, et cetera, et cetera, et cetera. So I just wanted you to guess the first one. Yes? No. Not Russia either. No one, huh? In 2016, I'm sorry? You're just going to start yelling countries like, all right. So the first one is actually Congo. or the Republic of Congo. And that's how many, that's actually the majority of it. 100-something thousand immigrants moved from, to the United States last year, followed by China, followed by Mexico, followed by Philippines, and then the rest of many other countries. So we still have a net increase in immigrants, and that's what is happening. This is actually a graph that I think is really cool. If you go back 100 years and you look at the history of immigration, this is not just the entire population, so, I'm sorry, the percentage of the population each of the years, but also the composition of that population. And when we talk about immigration, we talk about several waves of immigrants, and we have the waves in the early 1900s to 1920s, most of them from Eastern Europe, and Europe as well, so Italy, Ireland, etc., but most of them also from Eastern Europe, escaping some of the issues that were happening in Russia, Poland, etc. Then something happened in 1950. 1950. We, as a country, decided that we didn't want so many immigrants. And we set us a lot of rules, actually even stopping completely immigration from China. That's what happens in the 50s. There was actually a law that was passed. And look how dramatically the immigration to this country came down, and the percentage of immigrants living in the United States was actually smaller too. So not just that less people were coming, but more immigrants were leaving. They were going back to their country, etc. Of course, things got a little bit better in Europe after World War II and in Russia, etc. And many immigrants moved there. We have a second wave of immigration when things, in terms of laws, change a little bit, and many immigrants start to come from Vietnam, Laos, Cambodia, etc. A lot of those areas mostly coming because of escaping some of the issues that were happening there. And a little bit after that, in the 80s and 90s, we have a large immigration from what used to be the Soviet Union. Many of them actually ended up here in New York City. Most of them actually live, a very large population live in Brooklyn these days, a very large ex-Soviet Union, and the many countries actually live in the United States. But since the 70s, the majority of our immigrants are coming from Latin America, and about 66% of those immigrants are actually from Mexico. Now, as of about 10 years or so, although the majority of immigrants in the United States are from Latin America, the new immigrants are mostly coming from Asia. As I mentioned to you, those three countries, China, India, and Philippines, those three countries. So those are the new, yes?
I don't see any mention of the Caribbean.
Yeah, so it's actually minuscule compared to this large, but it's a very interesting actually history. And yes, they're actually sometimes included in Latin America, depending on what country you're coming from. Not all places in the Caribbean are Latin America, but they're either included there or they're just so small that they're not included in this. There are waves from the Caribbean, and again, it actually speaks a lot about some of the economical issues that happen. We have a very large number of Dominican republics here, Cubans, of course, since the 50s. We have a very large number of Cubans that moved to the United States with the wet feed, dry feed, if you have heard of that. I can tell you more later. But we also have many immigrants from Haiti and from other parts of the Caribbean. But I think comparing to these populations is very small.
The alarm condition of the 10th floor mechanical is still being investigated. Please stand by for further information.
If it's fire, by now we're gone. I mean, so. All right, so what about undocumented immigrants? So again, this is something that I just want to put the definition of undocumented immigrants, a very simple one out there, okay? Someone that moved to the United States, regardless of how they move. Someone that moved to the United States and decides to reside here, to stay, to live in the United States without the proper documentation, meaning without a visa, a green card, or whatever other paperwork that allows you to live in this country. That's what an undocumented immigrant is. Believe it or not, the majority of undocumented immigrants in the United States come to the United States with documents. Most of them with a tourist visa, or if they're from a country that doesn't need a visa, just with a passport. And they come through Kennedy, Miami Airport, Los Angeles, whatever it is, and they overstay their visas. And they stay and live, many for the rest of their lives here. There's a very, not small, but significant but small percentage that actually walk through the southern border and go through the desert and Maybe a wall will stop them. That's one of the things that I was going to say. But another thing that is important in terms of undocumented immigrants, of course, the absolute number has been increasing, and there are a lot of economical reasons why this happened, a lot of financial reasons why this happened, a lot of power from the farm industry in terms of bringing immigrants to do some work in specific areas of the country, and also some other issues that have happened around the country. But one thing that I wanted to point that I think is very important, that since 2005, 2006, there are less and less undocumented immigrants in the United States. And believe it or not, and you can believe it or not, there are actually less undocumented immigrants from Mexico today than what we had a year ago, 2 years ago, 3 years ago, 5 years ago, and 10 years ago. The immigration from Mexico, and sadly, many times when we talk about undocumented, we think first as Mexicans. We think about Mexicans. The immigration from Mexico is actually negative. There are less Mexicans moving to the United States here than what they are actually going back to their country. It's negative, including undocumented immigrants. This is not me just trying to give you some false information. I'm sorry?
It's not fake news.
No, it's not fake news, I promise you. It might be on Facebook, but it's not fake news. Yes?
Are you including in your, is that like people who are deported that you're including in this negative, or just people who are moving back for their...
So that's a good point. So that's actually one of the questions that it comes often when you talk about this. So what happens, we heard or we think that a lot of immigrants have been deported, or undocumented immigrants were deported during the, for example, the Obama years. And it's true. Not a lot more than what was happening when, with Bush, W. Bush, but yeah, about 400,000 undocumented immigrants were actually deported during those years. And yes, we do take that into consideration, but it hasn't changed that drastically from the 90s. There's a lot of, I have a lot of more information here. I don't want to touch too much in that, but the one thing that I want you to understand is that a lot of the policies in terms of deporting undocumented immigrants up until yesterday has not changed since the 80s. Really very little has changed. And yes, we have deported a lot, actually. Let's be very honest about that, especially in the past 10 years. But not a lot has changed in this graphic to make a significant change. What we do see is a lot less people coming to this country for the purpose of residing in this country without visa, etc. So again, we are talking about 11 million or so. So out of those 42 million immigrants living in the United States, about 11 of us are undocumented. This is a topic that many actually are listening today or are actually interested in these days. About 3 million of those immigrants right now are actually considered refugees or were refugees. Now they're actually citizens, migrated to the United States as refugee. And the whole refugee project started in the 1980s. We did take refugees before 1980s, but the program, the federal program for refugees started in 1980s and through the Federal Refugee Resettlement Program. One of the most interesting things about this program is that the federal government sets a ceiling for how many refugees we're going to get every year, before the year. So for example, the Congress and the, mostly actually, the President and the State Department, but in consultation with Congress, decided that for 2017, we're going to accept 110,000 as the ceiling. Okay, 110,000, as the country, we are going to accept 110,000. Not just that, but within those 110,000, the federal government tells us where they're going to come from. So for example, and I don't remember exactly numbers for this year, but it might be that 40,000 from Africa, 30,000 from Asia, et cetera, et cetera, et cetera. So we put a cap to where they come from. And I put a big question mark because, as all you know, we don't know where we stand in terms of this at this point. So the refugee program is in limbo right now, and we in no way think that we're going to reach 110. Not even previous year, we actually reached the ceiling. As you can see, in 2016, the ceiling was 110,000, and we accepted 82,000 refugees. And again, mostly as well from Congo, as I mentioned before. Yes?
How did they come up with the number?
That's a very good question. So it's based on a lot of different things. Much of it is politics, but it's a discussion about what is currently happening in the country. Where are the conflicts? Where are the places where most refugees are going to come from? This is an estimate for the future. So you're thinking that that's going to happen. It does, they can tweak it a little bit. Obama tried to tweak it with Syrians, for example, increasing that number last year. and based on that, based on states that are willing to actually accept them, because you have to incorporate them into the United States, refugees actually for the first year receive a lot of different, or at least are actually eligible for a lot of programs that other immigrants are not. So regular immigrants, even those that come from with a green card, might not even be eligible, for example, for Medicaid or for Social Security, whatever you can think of the federal programs. Refugees are for at least the first year, if not more. So it's actually costly, et cetera. So there's a lot of discussion with that. But I think to me, the most interesting part is that there's a geopolitical discussion of what's going to happen in the next year, and that's where we actually, that's what we accept. Believe it or not, in the past, I know today it's actually a little bit different, and it's very interesting that we're talking about this today, but in the past, some states have actually begged the federal government to resettle the refugees to their specific states because they needed actually workers in a specific area. Many immigrants actually moved to parts of the country that you wouldn't even think. So for example, very large, and no insult if anyone is from Minnesota or any other part of the country, but many refugees from Laos, for example, ended up in Minnesota. There's nothing actually other than the fact that the government decided to put them there first and gave them all the access to all these programs there. Many of them actually can relocate after the first few years, or immediately for that purpose, but they stay, and they actually grew as a population over there. So what happens this year? What's going to happen this year? Your bet is as good as mine. As far as I understand right now, the entire acceptance program is actually stopped. And this is actually a fairly large and complicated process. It takes about 2 years. It's through the UN and tons of other agencies. As far as I understand, those that are actually going through the process are completely in limbo right now. And again, we'll see what happens in the next hour or two. You're probably going to get a tweet or something. By the time we're done with this conversation, it's going to change. So, all right, so that's the population, a fairly large population of immigrants, 42 million. One thing that is very unfair that I'm doing right now is that I'm grouping all immigrants in one group. I'm putting all of us into one group. Totally unfair. Totally unfair. Why? Because we come from different countries, and this is the reason why I was saying it's unfair to say Latin America. You know, some of us actually come from Peru, with a Spanish-speaking country. Some of us might be coming from Brazil, with a Portuguese-speaking country, with a completely different background, culture, etc. Some of us might come from Guyana, a very large population from Guyana here in New York, barely taken into consideration in Latin America as a country in South America. So I'm grouping a lot of this. I'm grouping all the immigrant populations in this discussion. There's a lot to be said about talking specifics of each of the populations, and even within the country, those populations are. They differ in race, ethnicity. Those that come here with a visa might come here with a higher socioeconomic status. Those that actually move through come through the southern border, et cetera, et cetera. So there are a lot of differences that I'm not touching today for the purpose of time, but I'm more than happy to answer any questions. This is actually what I would like to discuss today and give you information about. Our work and the work of the disparities group that I'm part of aims at this. And I think you have heard this over and over. This is the main idea in public health these days, health equity. But it's true, we try. And this is our main goal, the opportunity to provide everyone with the opportunity to actually attain the highest level of health, regardless of everything else. That's the idea. So if you actually get pancreatic cancer today, thank you. Yeah, excellent. So if, why not? If you're diagnosed with pancreatic cancer today, okay, and you're unfortunate enough to have that diagnosis, and I am as well, our opportunities should be exactly the same, regardless of our race, ethnicity, where we come from, what we can access, what kind of insurance we have. That doesn't matter. What matters is that we provide to everyone the opportunity to attain this maximum health, whatever that is. Many of us might die. At the end of the day, we all do. But many of us will die in a year after that cancer, in 5 years, but at least we got the opportunity to access clinical trials, to access the care that we need, to access anything that you can imagine. One of the ways to measure health equity, or that we actually get a sense of what's happening in terms of health equity, is by discussing health disparities. And it's different. It's actually much more specific. Health disparities are just differences between groups in terms of health. So for example, is there a higher mortality among blacks in terms from cardiovascular disease versus whites? Is there actually a higher risk for HPV among Latinas or Latinos in general than non-Latinos, non-Hispanics? Those kind of numbers. You're comparing groups. And when you compare groups and you find that there's actually a significant difference, then you know there's actually a disparity there. In this case, a health disparity. And that's actually the areas that we try to address, that we try to reduce to attain, at the end of the day, health equity. One of some of the reasons why these barriers occur, and this is the main plate for this conversation, are the access to care barrier. And it is, as it sounds, it's accessing care. It sounds naive, it sounds very simple, but accessing care is one of the most difficult things that we can do. Now, you can think about access to care as insurance, really. That's the typical thing. Well, if you have insurance, you can just get the care that you need. Sure, but if you don't speak the language and someone give you, you go with your insurance and you get your treatment, and someone gives you like a whole, bunch of information describing how you need to take the medication, what you need to do, what you don't need to do, and you don't speak the language, you will not be able to access the care. Correct? If you don't believe in the treatment that your doctor is getting you, you don't think that's actually something that will help you, you will not be able to access that care. So there are multiple facets to, multiple aspects of the access to care, and we're going to discuss some of them in the next few slides. Any questions so far? I know there's a lot of information. The last part we can actually just look at the numbers. It's mostly about the specific numbers within specific cancer types, but this is perhaps the most important part to understand when you talk about immigrant populations and cancer disparities. These are not, by the way, unique to immigrant populations. Of course not. They can be seen in other minority populations. In this case, again, we're just talking specifically about immigrant populations. And as a group, so these are not just unique to Latinos or immigrants from Latin America or immigrants from Asia or Europe, but actually are more universal. So when we talk about financial aspect of access to care, yes, we talk about insurance. And yes, within insurance, we talk about ACA. And I'm willing to talk about ACA if anyone has any questions. Insurance does open a huge door to care. Absolutely. No question whatsoever. I'm telling you nothing new, correct? But insurance, first of all, is not enough. It used to be that insurance, for example, will not cover a preventive care. So how do you access preventive care? You have insurance, but you can't go and ask for a pap smear. Nope, that's not covered. You can't ask for a, and cover. You can ask, but it might not cover a colonoscopy for colorectal cancer. It would not be covered. Since the ACA, most of this preventive care is actually covered, has been covered. So there are a lot of minimum standards, particularly in the area of preventive care, that ACA, Affordable Care Act, does cover. So as you can imagine, this improved the care and has improved care to preventive care, to cancer prevention, among those that actually have insurance. One thing that I would like you to understand very well is that ACA or Affordable Care Act is not just this, markets and this fancy groups of insurance that are sold by God knows who and all these companies, but mostly and primarily it's actually an expansion of Medicaid, which is an insurance that actually covers a lot for those that are actually low socioeconomic status of poor to a certain level. So that's ACA. What is happening with ACA now? That's a good question, really. Well, it depends. It was supposed to be repealed many weeks ago. It hasn't. I think there's a lot of understanding that it's a lot more difficult, actually, than what it was first proposed by some. ACA covers right now more than 25 people, and the number of new ACA insurees or the new people been added to ACA was actually, I believe, about 8 to 9 million people last year. I mean, the open enrollment that ended in January. So it has grown actually tremendously. Most of them actually don't want to be expelled from that, but not just the 20-something million people, many more has been covered by the expansion of Medicaid. So that's actually the simple, and what's going to happen with ACA? I think your guess is as good as mine. It's going to be with us for the next year. Those that actually have insurance probably will retain their insurance. Many immigrants actually qualify for that, not undocumented immigrants. It's clear in the law specifically that undocumented immigrants cannot even pay out of pocket full value for ACA insurance. But documented immigrants do, and many actually have gotten that, and we have had the opportunity to recruit many to ACA. And again, what's going to happen with them? Probably within the next year, it's going to remain. What happens the year later, I'm not sure. Now, as you all know, we live in New York State, and New York State is very different than even New Jersey, than Pennsylvania, and of course, very different than other states around us. So where you live will matter a lot. It used to matter a lot. It will matter a lot more, actually, for your coverage and what you can actually access or get or the type of programs, et cetera. What's going to happen with these minimum standards of covering prevention, et cetera, we don't know. We really don't know, and I have no idea what's going to happen. So stay tuned. It's going to be very interesting. It's already been very interesting and sad, too. But there's another component of access to care, the financial part. Believe it or not, many of our immigrants, and this happens often, cannot actually access care because they cannot get the transportation needed to go to their appointments. I know it sounds ridiculous for many of us. How can you not go to your doctor if you actually if someone found you with and this is actually something that happens to us often, we find people, when we do some health fairs, we find people with sugar in their blood, glucose levels of 500, literally very close to having to go to the emergency room. And we find that, we tell them that information, we give them as much information as we can, and they still refuse to go to the doctor because they don't have the means to pay for transportation, who's going to go, how are they going to go back, how are they going to go there, who's going to go back and care for them, et cetera, et cetera, et cetera. Same thing for childcare. If you don't have the money to pay for childcare, you might make the decision, and many do, not to go to the doctor. And one thing that we're very interested in, and we do a lot of work, is with food. Many of our immigrant populations, and this is not unique of immigrants, but for this purpose, we're talking about only immigrant populations, many actually make decisions on a daily basis, either getting their cancer care, their chemotherapy, the radiation the next day, or buying food for their kids. This is no exaggeration. This is not on another country, in another place, not at all. This happens here, and happens in millions of cases. So it's a very sad state of affairs. But again, think about how accessing care can be from, and particularly the financial aspect of it, can be from multiple areas, not just from insurance. Yes?
If I may suggest another one, not being able to take off from work.
Oh, absolutely. Without paid leave or, yes, absolutely. No question whatsoever. Thank you for bringing it up. Yes, I mean, many actually of our immigrants work in on an hourly basis. If you lose those hours of work, you will not get paid. You're making a decision of either making money or going to get your chemotherapy or radiation. I know for some of us, and I'm going to repeat this often, I know for some of us might sound crazy. How can we not actually get it? We want to be alive and really want to try to actually win the fight against cancer. But when you actually have to deal with something that's so acute in terms of food, in terms of your kids, in terms of your daily life, many of us actually make the decision of not going to the doctor or not following the care that we need, not following through, maybe just starting, et cetera, et cetera. Someone, yes, Rosa.
Actually, I was going to say the same thing, that many of our immigrant patients and our cancer patients they have to leave their jobs, and sometimes they have to decide if they will go to the appointment and have to pay a copay for that appointment, or decide to stay home and save for that money, save the money for transportation, and work and do something, developing, earn some
Yeah.
Sometimes we have to think in a more spending way more with the patient itself, but the household, the complete household.
Completely agree. So again, when it's food, it's not necessarily food for them, as Rosario was saying, but it's actually food for the family. So am I going to pay for the treatment, or am I going to actually put food in the table for the entire family? Again, United States of America. This is not a different country. This is where we are now, even in New York. Yes?
Yeah, I would say if you're not accessing healthcare for
Mhm.
all of these reasons on a routine basis, I would imagine that would end up putting a greater stress on emergency medical services, because then, you probably go on until you're pretty much dropping dead. And,
Yeah.
and so has anybody tried to quantify kind of the level? I hear it from my doctor friends and former students all the time, right? That the ER is flooded with people who just need a checkup.
Yeah.
Or whatever.
So
Has anybody quantified that and seen whether there has been any kind of change in that response to the Affordable Care Act?
So it's a very good question in terms of usage of the ER as a regular source of care for general checkups, et cetera, because you don't access care for many of these reasons, and then you end up having to go to the emergency for an emergency, actually, as opposed to just a minor issue. So as always, the truth is in the middle. There are actually there is a slight uptick of usage of the emergency room by some immigrant populations. But there is a lot more of an issue in terms of delayed diagnosis or late diagnosis, in terms of not following through with treatment, et cetera. So yes, and it's not the issue that we have heard politicians talking about in terms of our emergency rooms are flooded by immigrants and without insurance or undocumented immigrants for that matter. It's not the case. We know that that's not the case. We do know for sure that there is a significant level of, for example, late-stage diagnosis, or for that matter, not even getting screening and prevention. That's some of the numbers that I'm going to show you that I think quantify some of these issues. All right. So what about the other the other issues or the other phases of access to care? Language. Language is something that we think a lot in terms of our group, and we do a lot of work with this. When we talk about language, we talk about limited English proficiency. If you have limited English proficiency, you might not be able to access care that is provided in English. And it's not just your doctor talking to you, but it's actually the prescription, is the forms with all this information, even walking through the hospital. If your hospital doesn't have a sign that it's actually in Spanish, how do you get to the suite to get your radiation or whatever else you need? When we talk about limited English proficiency, we talk about everyone that describe their English proficiency as less than very well. Even those that actually say that, yes, I speak English well, that's actually considered limited English proficiency. There are about 49 million people that actually are limited English proficiency in this country. As I just told you, there are 42 million immigrants, and not all immigrants, not all LEPs or limited English proficiencies people are immigrants. There are a lot of born in the United States people that actually don't speak the language very well, and for that matter cannot access care. But of course is an issue for those that actually English is their second language, ESL. Of course, if you have to learn the language and you might not be good enough, if your skills might not be good enough to actually have a conversation with a doctor, if you move late in life, it might be even more difficult to learn the language, etc. Another aspect of this is interpreting. We have the right to have an interpreter. If I go to the doctor and the doctor actually, or for that matter, the provider, whatever type of provider it is, a nurse, a physician assistant, if they cannot speak my language, if I cannot speak their language and I cannot speak English, I have by law the right to actually request and get an interpreter. And it should be a trained interpreter. It cannot be your kid, your daughter, 13-year-old, whatever it is. It cannot. It should not. It should be a trained interpreter, because this is a serious conversation about a serious topic that should be interpreted, should be transmitted as it would be in English. And we try to do this, and we train interpreters, and we do a lot of that work. Memorial does a lot of that work here as well. There are many different types of interpreting methods that can be used. Some of them are better than others. Some of them are person in the room versus person in the phone, et cetera, et cetera. But it is just keep in your head that it is actually a right of our patients to receive this type. There's a question in the back first. Yes. Yeah, when I did my fellowship, actually, we had a woman that was diagnosed with stomach cancer from an immigrant from China who had her daughter, who was 12 years old, interpreting for her in one of the hospitals in the area. That's just, I mean, it's not right for the kid for all purposes, but it is, of course, not right for the outcome. Really, you're not, a 12-year-old person should not be, and by law, should not actually interpret. But even if we do have an interpreter, it should be a trained interpreter. So I don't want you to think that interpreting is just something that anyone can do. I should not be just going there and Spanish is my native language. I should not be in the middle, in between a patient and a provider and just translating or interpreting for them. I'm not a trained interpreter. I should not do that. There's actually a lot to be learned, and we actually have a full course. We train a lot of the interpreters. Yes?
I had a patient, not here, but she was from Italy, and so she only spoke Italian. Everybody in her family spoke Italian, and they came here just to see this one surgeon. And in the hospital, they provided them with an interpreter, and it was all very nice. But then as soon as they were discharged, all of her outpatient instructions, all her discharge notes, all her prescriptions were all in English. And they like felt bad about like sort of complaining about that because they'd already felt like, you know, they knew they were being sort of a burden on hospitals by needing the interpreter all the time. And then here they were handed this thing in English, and she had no idea how to give her any of her meds because they were all not written in any way she could understand.
And just to add to that, if you think that you can just get a form like, you know, we do many times now, for example, an information sheet, and just take a picture with Google and translate it into whatever language, and that's going to be fine, it is not true. Why? I don't have anything against Google, and Google translation through pictures is pretty cool, but how do you guarantee that it's going to follow the same literacy level that the actual original form was? And it's supposed to be written at a 5th grade level, for example, to keep on, to be able to access everyone, or provide information to everyone that has, regardless of their literacy level. So no, it will not guarantee you that. It will not guarantee cultural issues. It will not guarantee words that actually might not be used in Italy or anywhere else. So no, it's not the same. And these small errors end up actually causing very big problems. And we know that they actually have impact, a great impact in the outcome of the patient in terms of their care, their management, et cetera, et cetera. Any other questions so far? Yes?
Bilingual doctors need to use interpreters as well?
So that's a fascinating question. So we don't have, at least in the United States as a country, or even the States, we don't have a test to assure that you're bilingual, for example. We can tell that I speak Spanish, and I can tell you that I would be okay talking to but there's no way for someone outside to prove that as of today. There's no test or anything like that. In general, most hospitals actually do let their providers use their native language or the second language that they feel confident when they have patients that speak that language. So there's no specific test, but what we use is basically a self-reporting. And we try our best. I mean, some of our groups are doing studies on how well we self-report our proficiency in that second language. We might be great going to Mexico and buying a beer. That doesn't mean that you can discuss actually a sexually transmitted infection with your participant right there, or AIDS, or whatever it is. And it's as laughable as that example sounds, it does happen. Actually, one of the studies that we did long ago, we recorded physicians talking to their patients in a second language. So for example, in Spanish or whatever language was, some other Chinese languages, Mandarin, etc. Some of the words that the physicians were using were absolutely amazing. And you would think that the participant would say, the patient would say, like, I have no idea what you're talking, doctor. I have no idea what you're saying. It sounds crazy. No patient says anything to their physician when they're telling them that they should clean their ears with their elbows, just because it's a mistranslation of whatever they're trying to say. It's fascinating. Yes, someone.
The one that I've heard, I'm sure you have, is when culturally you say that a test can be back negative.
Yes.
Directly translate that. And I think that it comes across as being that the person does have what the test is.
Yeah. Yeah, absolutely. Anyone here native speaking Spanish speaker? Okay, so if I tell you that I'm intoxicated and just translate it directly, what does that mean? Like, I go to you and say, I'm intoxicated. You're drunk, really? That's one of the first things that we think about. In English, is not necessarily drunk. Most, in the emergency room might mean that you're intoxicated from something else, from medication, etc. Words matter, and how they actually use in different languages matter, and knowing that matters when you're communicating with someone. One thing that I'm actually fascinated to is assumptions of the language. So for example, we see someone that is from Mexico. We know that they just moved a year ago. They look like Mexicans, whatever that means, and they report Spanish. So we assume that participant speaks Spanish, for sure that patient speaks Spanish, and we are assuming that's their language. In many cases, believe it or not, that's not their native language. It might be Mixtec or whatever it is of a second language in their country of origin. So now Spanish is their second language and English is their third language. So now we're doing the same thing where we try to speak in Spanish. Now it's very difficult to deal with those cases, but again, something to be conscious about. Not all of us that actually move from Latin America speak Spanish. All aspects of healthcare information is difficult to access if we cannot actually understand it in our own language. Finally, a cultural aspect of access to care. This talks about more of illness causation. What is actually causing the disease? What is actually doing? Why am I receiving this treatment? Where do I go to get treatment? Do I go to the family healer that we trust, and then after that, if nothing works, I go to the doctor? Do I follow radiation? It sounds crazy. I don't want to be radiated with anything. I heard that chemotherapy is terrible, so I'm not going to hear it. I don't want to even hear about this information. Do we trust that? One of the stories that I tell, is this being taped by any chance? Good. Oh, so I'm going to talk about my father here. One of the stories that I tell about it is actually, for example, my father walked for 5 years with one of his testicles the size of an orange. And he thought that it was perfectly fine. Perfectly fine. No, he didn't even complain about it. And then 5 years later, when he started to have severe symptoms, he just said, oh, I have this, by the way, that started 5 years ago, and it's been this size for 5 years, ended up being cancer. So how we decide not to take care of ourselves or not to care for what is happening, it actually has in many ways a cultural component. When we talk about tuberculosis, HIV, HPV, any of these issues actually are very difficult, very different to discuss in one culture versus the other. And it's really interesting and very important to understand the background of your population. Again, treatment trust, traditional healing methods, all these are issues in terms of the cultural aspect of accessing care. If you put all this together, and all of this all of these are affecting your population, you might end up getting a negative result. And we see this often, at least in the area of cancer prevention. And this is actually where I'm jumping next. Any questions so far about this? We're going to talk about the most typical ones: breast cancer, colorectal cancer, cervical cancer, and prostate cancer. I'm going to try to go a little bit fast here because there are a lot of numbers. I'm much more interested in hearing from you and if you have any other questions too. This is just for background. We estimate that in 2017 there are going to be around 1.6 million, 1.7 million new cases of cancer in the United States, and about that many deaths, 600,000 deaths from cancer. Cancer is going to become, if it hasn't, it's going to become the first cause of death in this country. As we get older, our population live longer, etc. It is an issue that we care, and that we care so much that we actually put a lot of money and a lot of research into it. What about breast cancer? We have about 255,000 cases of cancer a year. This is estimated for this year. About 41,000 cases, and about 90% of those are actually diagnosed today will survive for 5 years. About 90%. Treatments for breast cancer in general have improved tremendously. Breast cancer can be detected early. It cannot be as what we have now with the test that I'm going to discuss with you. It cannot be prevented, meaning that we cannot stop that cancer from becoming cancer, or that breast tissue from becoming cancer, but we can find it very early, and we can try to actually minimize the consequences of that cancer. The most important test is the mammogram. There are other ones that actually are very, these days, the self-breast exam, etc. All those are recommended, but not necessarily are part of the guidelines. How we recommend in terms of screening for breast cancer, these are the two institutions that are the most important ones out there providing guidelines for cancer screening and prevention. The American Cancer Society, they actually, it's actually the opposite. I'm sorry about that. No, this is okay. I'm sorry. The American Society actually says that in their guidelines today that between 40 and 44 years of age, your mammogram is optional. That didn't used to be like that. 2 or 3 years ago, it used to be that every year you needed to get a mammogram. These are for average risk women. Okay? There are many actually women that have higher risk, and their providers might actually change this. Between 45 and 54, mammogram every year, and 55 and older, mammogram yearly or every other year. The U.S. Preventive Services Task Force, a task force that is part of the federal government that proposed these guidelines, actually made a lot of noise last year by changing the guidelines on breast cancer, and these are what they propose, a little bit different than the ACA. Between 40 and 49, it's your decision. You go and discuss that with your doctor. Whatever you want to do, if you want to have a mammogram, that's fine. If you don't want to have, that's fine, as long as you understand the risk and the benefits of not having one or having one. And after 50, up to 74, you should get it every 2 years. This might be a little bit different than what you have heard, but this is actually what one of the most important groups that discuss preventive care actually recommend. They don't recommend at all, based on the evidence, they don't discuss clinical breast exam or self-breast examination. All of those, if you ask me, might be actually important, but by the time you get that lump, by the time you find that lump, might be actually too late. These are the recommendations for early detection of breast cancer. So what happens with breast cancer, and where are all the disparities that I was telling you about? Where are all these access to care issues come into play? Well, here. So we don't do a great job in terms of screening the majority of the population. We're about 71%. That's the overall screening of women with a mammogram every 2 years for those eligible. Healthy People 2020, which is actually the goals of the federal government in terms of our health as a country. The government sets these goals every 10 years. Healthy People goal is 81%. We're far from that. But what's more important here, and this is the reason why I'm bringing it up, is because if you look specifically at the immigrant population, then the rates actually go down by significantly to 62%. And more importantly, if you look at those that actually migrated here less than 10 years ago, the numbers are very, very small. Why? Most of it is explained by what I actually mentioned before, by lack of insurance and costs, for that matter, by language issues, and in many cases by cultural issues in terms of beliefs on fatalism, and if I'm diagnosed with cancer, it's over, or if I'm diagnosed with cancer, that's what I needed, and that's what is going to happen, so there's nothing that I can do, et cetera, et cetera. One other difference that I thought it was interesting, these are disparities comparing groups. 66% versus 44% among those are citizen versus non-citizens, and this talks a lot about the access to health insurance and other financial and socioeconomic issues as well. What we know of breast cancer disparities, we know that the screening rates, by the way, the screening rates for all these types of cancer have plateaued. We were doing well in terms of increasing the rates, but for the past several years actually has been very, very steady and without increasing. So that 71% actually, or that 70-something% is actually lower than we used to be even 4 or 5 years ago. So in general, we don't do a great job, but what most importantly is that we know that having insurance, we know that having a usual source of care, and we know that having a recent visit to a doctor, either a OBGYN or regular doctor, increases your chances of having a breast screening test. And this might make total sense. Of course, if you don't go to the doctor, you cannot get the test. But this is what access to care tells you. And this is what actually barriers to access to care have an implication over. And I'm going to try to run through this. But the most important part, of course, of breast cancer screening is actually, or the disparities, is that providers are not necessarily recommending this test, are confused by the guidelines, they don't have the time to discuss these issues. And our immigrant populations just tells us directly, I did not get a recommendation from my doctor. If they do, if they recommend it, I will probably get it, and most of them actually do. Colorectal cancer is actually a preventable cancer. It can be prevented through a specific test. But just to give you some numbers, these are the overall cases, death, and the relative survival, much lower than breast cancer. Both the ACS and the USPSTF actually propose the same preventive guidelines. Our recommendations, we can do, starting at age 50 for simplicity, we can do 2 tests. We can either go through what it's called a stool-based test. Basically what we do is we grab a little bit of stool and we test for blood through different mechanisms. That's done actually every year or every 3 years. We can do that, and that actually finds blood, which means that there's already some changes in the colon, probably cancer already. So it's what we call early detection, hopefully, or screening. Or we can go with what it's called direct visualization, which is actually a colonoscopy, which is a camera that visualizes your entire colon. And if that camera finds what you might want to call a pre-cancer, which is our polyps, that camera can actually, through that camera, we can cut those polyps and we can prevent those polyps from developing into cancer. Make sense? And that actually colonoscopy is every 10 years. Those are the recommendations. After 85, it's actually after 76 is individual decision. The overall screening 55, not doing great. Most importantly, among immigrants, 41%, and within those that just migrated to the United States, so the previous year, 20%. We know, again, I know it sounds repetitive, but this is what we know, and we have plenty of evidence on this, that having a regular source of care, having insurance, does play a significant role in terms of increasing CRC screening. Of course, English proficiency, cultural beliefs. One of the issues that we have with our Latino populations, for example, is what we call, or we have discussed in terms of the rectal issue, in terms of like, nothing go through there, no way, thank you. And convincing someone that they actually want to put this scope through their rectum, anus rectum, and then through the entire colon to try to actually find something, regardless if they're completely asleep, etc., they won't necessarily agree. There's actually plenty of immigrants that believe that colorectal cancer is actually caused by having anal sex, which is not true, at least for this specific cancer. And they will not actually agree to a colonoscopy because they've never had anal sex, according to them. So there are a lot of cultural issues and cultural beliefs. This is a very difficult test to recommend and to make your population to adhere to it, because you have to actually prepare for the test, et cetera, et cetera. Provider recommendation is the most important part. We're not doing a great job in terms of giving it to everyone or recommend to everyone. These are the number of cases in terms of cervical cancer and death. The relative survival is for actually invasive cancer. So it's the worst case of cervical cancer. Prevention, this has changed, and it's actually, the guidelines are in the process of changing again. At least the USPSTF is actually studying this. But as of today, as opposed to what many might actually think, the screening for cervical cancer with a Pap smear should start at age 21 for everyone. Regardless, it used to be that if you had sex 3 years later, none of that. It's actually 21, everyone. And between 21 and 29, we do a Pap smear every 3 years. It used to be every year. We recommend every 3 years. If you feel that this is not good enough for you, you can talk to your doctor about it. No question whatsoever. This is what these two organizations recommend, and what most actually Department of Health, et cetera, follow, what most insurance cover as well. Between 21 and 29, Pap smear every 3 years. After that, starting at 30, you can have a Pap smear and a test to identify human papilloma virus every 5 years, between every 3 and 5 years. Why we don't do HPV before 30? Because probably most of us have it. And if we test, 80% of the women, or the women that we test between the ages of 21 and 29 will probably have HPV. The good news is that the minority of them actually keep the HPV as a chronic condition. Why I'm discussing HPV? Because 95% of cases of cervical cancer, 95 to 99, are caused by the human papilloma virus. Okay? I'm running through this because I know that we're actually running out of time, but this is a basic concept of cancer screening and prevention for cervical cancer, and this has changed. I don't know if you know this, but Papa Nicolau, which is actually a doctor who developed the Pap smear, he actually, when he was developing this test and figured out that this was actually a good test to screen for changes in certain tissues of the body, he was doing a pap smear to his wife every day for 45 days. Go ahead and read it. It's fascinating, the stories of the wife. So if anyone is complaining for every 3 years, you should think about that. Yes?
I was just going to ask about the HPV vaccine.
Yes.
I know they recommend
Yes, go ahead.
under the 26, but that's not like a law. It doesn't mean that you can't not get it when you're older.
Okay, so very good question. I have a small, that's actually the area that most of my work is on, most of my research. So I don't have a lot of that, but I'm happy to answer that, and I have a slide on that. Before this, I just want to, these are the rates. You can clearly see disparities here. The majority of cervical cancer in this country, even though it's not one of the most common cancers in the United States, it is the most common cancer among women in the world, one of the rate of a pap smear, the rate of screening is much lower than the general population. And again, for those that just migrated to the United States with much higher risk for it, it's again much lower. In terms of prevention of cervical cancer, we do have the HPV vaccine. HPV, or human papillomavirus, is an infection. It causes actually 95 to 99% of the cases of cervical cancer. The HPV vaccine, the ones that we have now, there are 3 vaccines now, although we only use what is called the HPV-9. It potentially can prevent up to 95% of these cases, 95% of these cases, and up to 100% of genital warts as well. And it's actually given in 2 or 3 doses. This just changed as well since last year, at the end of last year. 2 doses for those that actually are younger than 15, 3 doses for those that are 15 or older. So the question is, can a person that is actually more than 26 years old get the vaccine? The vaccine was studied, and it's recommended by by us, all of us, by the FDA, to for people between the ages of 9 and 26, boys and girls, women and men. Can you get it later than 26? Yes. Yes. Who should get it after 26? We give it, for example, to people at higher risk. We recommend it very often to people that have men who have sex with men who actually also are HIV positive. We recommend it very often, even if they're actually older than 26. We recommend it to specific populations. The reason why we don't give it after 26 is multiple. One of them is that it hasn't been studied yet for that older population. We don't know if it's actually effective. We don't know if it will produce enough antibodies. But also, what I told you before, at age 26, if you look at us as a population, I'm not talking about anyone specific here, but as a population, at age 26, the chances that you already got HPV, and you might have it with you, are enormous. Sorry to tell you. About 80% of us actually get the HPV. It's the most common sexually transmitted disease. Again, the good news is most of us will just, our immune system will happily defend us, and we won't need it. Guys and girls, yes. So we rarely recommend after 26. We do a very lousy job in terms of providing this vaccine. There are tons of issues here, political issues, religious issues, knowledge issues, tons of issues, even within our immigrant populations as well. About 42% of adolescent girls actually are eligible for this vaccine, are getting it, compared to, for example, 85% in Australia, where they give the vaccine in schools. And Australia has already seen a decrease of about 80% in cases of genital warts in their high school population, which is one of the first outcomes that we will see because cancer takes a while to develop. Among boys, this was not recommended until 2010, but still we're doing a very bad job in terms of vaccinating their kids. And the Healthy People 2020, which will probably become the Healthy People 2050, is actually 80%. We're never going to get there in the next 4 years. Definitely not these days. Predictors or facilitators for cancer, for cervical cancer, are the same that we discussed before: having insurance, having a regular source of care, longest stay in the United States, et cetera, et cetera, et cetera. See how these things repeat. And these things can be used to either create programs, inform policies, make decisions about how to actually implement interventions to deal and increase and reduce these disparities or increase screening. All of these are actionable areas, and that's the cool thing. That's what most of us are working on. Finally, and this is actually a bit of an issue, our immigrant populations actually have higher rates of, mostly from, you were asking me for populations from the Caribbean. Prostate cancer is has a higher rate among men from immigrants from the Caribbean. In general, in the United States, that's how many we're going to have. That's how many deaths. But this is the important part, and this is where I don't want to create problems, but you might have heard about prostate cancer screening. But 100% of those that are diagnosed today will live for 5 years. Okay, almost everyone will actually survive for 5 years. And if you think about surviving for 10 years, about 98% of those that are actually diagnosed now will survive. Many of them without any treatment or anything like that. And this is the reason why screening for prostate cancer these days, it's actually controversial, to say the least. Guidelines might be changing these days, but as of now, the USPSTF does not recommend screening for prostate cancer. Now, this is for average risk. If for any reason your risk is higher than average, then your doctor might recommend to get a test, which is actually 2 tests. One is a blood test, which is the PSA. The other one is a digital rectal exam to try to find to touch the prostate and try to find a tumor, etc. But you might say, well, why are you bringing it here? Because we are actually encouraged to discuss this with our participants. We're supposed to tell them, look, the reason why we don't actually recommend to everyone, but you might want to do it, is because the risk versus the benefit, the consequences of surgery versus the consequences of not doing anything, the fact that it's a complicated conversation. Now use an interpreter. Talk to someone that actually has a completely different cultural background. Someone that thinks that prostate cancer only happens in a specific, people that do specific things. Someone that thinks that once you diagnose with cancer, you're actually going to die the next day. You don't have to do anything. It is a very time-consuming, very difficult conversation. And sadly, we don't pay providers to actually talk. We pay providers to do this stuff. So these conversations don't happen often. The ACA recommends that if you're 50 years or older at average risk, you should at least, and you think that you're going to live for at least 10 years, or the provider thinks that maybe recommending PSA test, a blood test, or a digital rectal exam might be useful. The USPSTF does not recommend at all. I mean, just have the discussion. Now, why am I bringing here? These are the rates of screening for prostate cancer. It really don't say much because we don't recommend it all the time. So 35 is low, but what it is important is that within our immigrant populations, we do have at higher risk populations. For example, the ones that I was mentioning to you, immigrants from the Caribbean. So screening those, or at least talking about this topic, is very important. And look how well we do this. These are just some of the issues in terms of disparities. Look how well we do this. Only 3 to 7% of men 40 years or older who are also immigrant have had actually a discussion with their providers in their last general checkup visit about prostate cancer. The goal actually, according to Healthy People 2020, they're actually very conservative there. It's only 15% in terms of men discussing the issue of prostate cancer, making a decision, whatever the decision is. Among immigrants, only 3 to 7%. Think about all those access to care issues, language issues, cultural issues in terms of having this discussion. It's a very, very difficult discussion, and we do a very lousy job, even though we know that we have actually a higher risk population. That's all I have. It's a lot of information that I would have loved to have hours to discuss with you. You might not, but my hope was to actually introduce you to who we are as an immigrant population and where we're coming from, what are our issues in terms of accessing care, and how those issues can actually reflect, as we were discussing before, in tangible information, in this case, specifically in cancer prevention. So any questions? Thank you. I know we're running out of time, but I'm happy to stay for questions if you have.
I was going to ask, so are there particular studies that look at healthcare providers or healthcare settings that just do a better job with prevention?
Yeah. So I do some work on that area, and I'm fascinated by that. There's actually plenty of evidence and what is best, what are best practices for providers. There's a large number of interventions that have proven to be successful, from the typical cultural competency and understanding your population and the risk of your population, to actually providing better, educating providers on how to educate their participants in a low literacy level, et cetera, et cetera. As far as I know, and this is based on the evidence that I have read, a lot of these actually work, and I'm not trying to be too negative here. A lot of these work, but they work in very specific settings. Rarely a project actually, an intervention for these purposes have worked in the general population or the general hospitals in many different populations for many different immigrant populations. But if there is something that I would say about that, is that if you understand your population well, not for the purpose of treating each patient depending on their unique characteristics, but to understand at least the characteristics of the majority of the population. So making you culturally competent for your population, your patient population, providing the services that are needed, language interpreting, etc. Having signs for your patients to go from point A to point B in your hospital. Understanding that if you tell your participant that you're going to have to get your patient, that you're going to have to get chemotherapy 8 days a week for the next 3 weeks, and it's going to be at 10 in the morning, that participant might not do it because they actually don't have any place to leave their children. That they might not do it because they don't have a place to, a way to actually get here. They might not do it because they don't have the money to do it, the insurance, etc. So being aware of these issues does actually have a consequence in some of these numbers. It's a very difficult thing, and as I mentioned before, cancer screening and prevention, rates of cancer screening and prevention have actually plateaued and in some cases gone down the past few years for multiple reasons. Yes?
I was wondering, for immigrants who come to the U.S. with young children or who have children here, what happens to these home security measures in the next generation?
Yeah, that's fascinating. So it depends. It's one of the most interesting things. What happens with the second, third, fourth generation of for example, Latinos, Asians, etc. It depends on each of the cases. We know, for example, in breast cancer, the rate of breast cancer, the incidence of breast cancer among the second, third, and fourth generation might increases. So there's, to put it in a raw way, there are more cases among the second, third, or fourth generation than the first, or those that actually moved to the United States because of the environment, because of whatever you can think of. There's a lot of information on that in that regard. But we also have positive things. For example, we know that it's more prevalent. Having a pap smear is a more common practice among second, third, or fourth generation than immigrants or immigrant movement. So yeah, so it changes and it matters. English proficiency changes, cultural background changes, the process of acculturation, which is not something that I love because it really doesn't talk a lot about some of the issues that happen with all of us when we move to another culture, but the process of acculturation does actually modulate in many ways how we care, how we actually access care, etc. And in some cases for the better, and some cases for the worse. So, for example, for obesity and eating habits is the worst. I mean, I didn't touch about risk for cancer or anything like that, but we know that immigrants come to this country, immigrants as a whole, okay, the entire population, they move to this country and they have anywhere between 20 and 40% lower rates of obesity and overweight than the general population. After 4 years that they have been here in the United States, 4 years, not a generation or the second, the third, no. After 4 years, the rates of obesity in that population is exactly the same as in the general population. So that's a negative thing, and that can be attributed to the some cultural issues, some access to food, the family interactions, et cetera, et cetera. There's a lot of evidence on that as well. So it can go either way. Something to know, to use when you're actually practicing on or implementing a program or trying to understand a new intervention, et cetera. Information that is very useful. There's plenty of evidence on that. Yes?
Thank you so much for sharing.
Thank you. So for immigrant populations or for the general population as a, yeah. I can, as you said, I can have a conversation of 2 hours about this. You asked me for my personal opinion. I don't believe that some of the ideas that are actually discussed today will actually have a significant impact in the immigrant populations in the near future, nor in the medium or long term. That's what I think. That's based on what I see and the evidence that I know, that I have read, that I have seen. But it's a way to try, and I'm all for that. I mean, it's a complicated topic, and it's one of those things that actually takes a long time to find, if there's any change in outcomes, et cetera. But what has been discussed so far, I don't see how that's actually going to change any of the ones that I mentioned, at least today. Not that I can think. I might change my mind in the next 5 minutes and tell you, but not that I can think of. Yes, I'm sorry. Yeah. So again, a topic that I would have I teach actually immigrant health, and I have taught many times immigrant health, and that what you just described is the whole class. But I'm going to try to be succinct and try to explain you why I think it's one of the what are some of the issues. It comes down to access to different programs, mainly insurance, etc., but accessing programs in general. In 1995 and 1996, welfare reform passed. As you probably will know, it's called PERWORA. You can find it online and read it. It's not that complicated to understand, but it is one of the major welfare reforms that have occurred in this country for the past, in the past century. But most importantly, it changed the rules for the immigrant populations tremendously. And how? In a very simple way. I'm not being very specific here for purposes of time, but in a very simple way, it actually stopped new immigrants from accessing those federally funded programs for 5 years. So the law of the land, even today, is that if you're a new immigrant, if you have been here only for a year or two or less than 5 years, you cannot access, for example, Medicaid or any of the programs that are even partially funded by the federal government. To me, that's actually one of the most important aspects. It's not the only one. Might not even be the majority of one, but it's actually a very important one. The second one is, of course, the accessing care for all these other purposes is complicated. When you move to another country and you're trying to navigate the new social norms, the new issues in the country, trying to find a job and get comfortable with the language, etc., accessing care might not be priority. And cancer screening might not be your priority. You don't want to be diagnosed with cancer when you're in the middle of your, trying to come up with your life and putting together your life. So it might be at the bottom of the totem pole, and we might not care about it. Language issues, the longer you stay here, the more you're familiar with the language. Again, most of the issues that I mentioned today are important, but I think one extra component to what I mentioned today is this accessing to federally funded programs for the first 5 years, and it's actually a significant issue. Now, every state is different, and some states, for example, in New York, might give more benefits to even undocumented immigrants or allowed undocumented immigrants to access some care versus those that are actually in Alabama or some other place or Arizona. So it differs. So that's why I was saying at the beginning that talking about the immigrants as a one group, not just because it's difficult, not just because they come from many different places, but because they live in 50 different systems as well, that in many cases they have different ways to accessing care, et cetera. So I think it's a multifactorial issue. That issue of PERWORA, though, although I did not discuss it today, I think it's very, very key. So welfare of 1995-96 is one of the main issues in terms of accessing care for new immigrant populations.
Maybe one last question?
Yes. I'm curious, I'll answer your question and with all honesty too, and based on a lot of the evidence that I have happily read. But I wonder why you see telemedicine as something that might actually reduce some of the disparities in immigrant populations. What would be the...
Essentially, under the slide of financial barriers, we had mentioned they have big opportunities. And there's a huge country here,
Yeah.
right? It's not just New York City where we're half an hour away
Mm-hmm.
Handy in terms of eliminating that kind of community.
So a very good example. And for some issues, I definitely see your point. I think for the core issues of disparities among immigrant populations, or health disparities among immigrant populations, I fail to see how telemedicine has actually could make a big difference. Now, telemedicine has not been what we thought it was going to be. So just for the general population, we thought it was going to be a stronger thing, a way to actually disseminate services much easier, accessing services much easier. And it hasn't shown to be, or proved to be, as good as we thought it was going to be. It does work in certain cases, et cetera. One thing that I would love for all of you to actually understand, that particularly for immigrant populations, is that although it sounds that one of these barriers or one of these aspects of the barrier might be the most important one, for example, insurance or transportation or whatever it is, it's not. It's a multifactorial issue. It's actually, so yeah, you might actually be able to put a screen and put a doctor in front of you, but will the doctor have the time to explain these issues? For example, for cancer screening, the prostate issues, and have a long conversation about risk versus benefit. What are the consequences of having surgery versus this other surgery with just living with cancer? So that's one thing. What about interpreting? Do you still need interpreting? What about the health literacy issues? What about the cultural issues? I'm not trying to say that these are impossible issues to address. And for those that actually live in some rural places or places with no, for example, here is what I think is actually, we might agree. Immigrants have actually, in the past, particularly the past 10 years, have moved to places in the United States that were rarely immigrant cities. For example, most immigrants used to move to California, New York, Florida, Texas, etc. Many actually have moved to Vermont in the past 10 years, to many places in the Midwest, many places in the South, New Orleans, etc. Many, many places that are not used to it. They don't have the services. They might not have providers that speak languages. So maybe telemedicine might actually be able to offer at least some of that. So that's one area. Telemedicine might offer actually a remote interpreter. And we do some work with that, for example, where you actually have a remote interpreter. It doesn't matter where in the world, that it's just interpreting for you and this other person that is hundreds of miles away. So we can actually overcome some of these barriers. I don't want to I answer your question too very similar, like almost like in a negative way, but I fail to see how telemedicine will make a significant impact, particularly in cancer care, cancer screening, prevention, et cetera. Maybe to manage diabetes, manage blood pressure, some of the things that we still have disparities, by the way, in the immigrant populations might make a difference. But for cancer prevention, I'm not sure. I'm going to think about that, though. But it's interesting. It's a very good question. I'm happy to answer other ones, but I know we're running out of time. So
yeah, I think if anybody has any more questions, I think Dr. Aragones would be delighted to speak to you. I want to thank you for a wonderful talk, sharing your knowledge and your passion.
Thank you, everyone.
And thank all of you guys for coming. I hope this is the first of many of these. We'll reach out to you with a survey to get your feedback and might ask things about like what time of day you think works. We didn't want to do it too late or too early, so we'd love to get your feedback on that and on what topics you might like to address. I think we could have you, Dr. Aragones, give us 4 more talks. So,
anytime.
All right. Thank you so much.
Thank you.